Warm greetings to one and all. I'm Dr. N. Komalin Prabhu, Assistant Professor from Department of Oral Maxillofacial Surgery, SRM Dental College, Namapuram, Chennai. I'm going to present on the topic bone regeneration and periapical osseous defects using an osteoinductive biomaterial comprising of platelet-rich plasma, calcium sulfate, and autogenous bone graft. Reconstruction of bone defects following surgical management of pathology, tumor, impacted tooth, or even maxillofacial trauma represents a challenging problem for the surgeons. There's a constant research which always tries to improve the success of bone grafting with autogenous bone and also helps to innovate on osteo bone substitutes and growth promoting factors. The biology of bone regeneration is very complex, involves the coordinated expression of growth factors. What is the role of PRP bone substitute in autogenous bone graft on bone regeneration? The bone substituted graft forms a new bone via osteoconduction from adjacent osteoprogenitor cells. An autogenous bone graft forms a new bone via transplantation of osteoprogenitor cells from distant site. Thus, an autogenous bone graft places many osteoprogenitor cells into the graft site. The PRP upregulates the osteoprogenitor cells into the grafts and helps in the matrix formation. The calcium sulfate is used in our study. Basically, it acts as a functional barrier in direct tissue regeneration by physically halting the soft tissue proliferation by means of osteopromotion principle. It gets completely resolved in a relatively shorter time period, provides a local increase in calcium ion concentration, which may stimulate osteoblastic activity and acts as a scaffold for bone growth. A combination of calcium sulfate and factor-rich plasma helps to release the growth factors in a time-dependent manner. The calcium sulfate and factor-rich plasma, which is initially moldable, helps to maintain the space and also acts as a scaffold which is needed for the bone regenerative process. It acts as a functional barrier by impeding the migration of the epithelial cells from the skin into the bone defect, and also it helps to facilitate the formation of bone. The aim and objective of our study is to compare and evaluate the bone regeneration with and without combining PRP, calcium sulfate, and autogenous bone graft in periapical defects of the jaw. To evaluate the increase in the bone density radiographically by grayscale method, to calibrate the percentage increase in bone formation by measuring the residual bone defect size in pixels, comparing the mean radiographic scores by four independent blinded observers between the study and the control groups. It's a 2-year prospective study which included cases where surgery was done for periapical periradicular osseous defects following cyst enucleation. Institution clearance was also obtained for the study. Prior surgical consent from the patient was taken. The patients of age group from 12 to 50 years were included in our study. Patients with cystic bony defects of mandible and maxillary region, both small and large lesions, with minimum of 0.5 to 1.5 centimeter to a maximum of 3 to 3.5 centimeter in diameter was included in our study. These are the exclusion criteria. Patient with systemic diseases, especially uncontrolled diabetes, renal disorder, respiratory problems were excluded. Age less than 12 years and greater than 50 years, regional malignancy and chronic focus were excluded. The overall picture schematic summary of the materials in the we included 20 patients who are primarily having a osseous defects caused by periapical cyst. The study group, as already stated, which is comprising of PRP, autologous bone graft, and calcium sulfate. The control group was performed with normal healing with PRP, autologous bone graft, and calcium sulfate. They were randomly divided into two groups. A pre-operative questionnaire was undertaken. Surgery procedure was carried out by the same surgeon. Then a radiological assessment was carried out using OPG and occlusal radiograph and IOPA, which were taken at pre-op, intermediate, post-op, 5th week, 13th week, and 20th week. The occlusal and the IOPA radiographs were digitally converted using a digital camera. We used three important methodology. One was just by using a radio opacity scoring scale, which were evaluated by four independent blinded observers who are not part of the study. Evaluating the bone density by means of grayscale analysis using Coral Photopain X-ray software. Measuring the residual bone defect in pixels using Coral Photopain X-ray software. The PRP preparation was done by tabletop centrifugation device using a double centrifugation technique. The first spin was also called as the hard spin. Then this spin was undertaken at a speed of 5,600 rpm for 3 to 4 minutes. The second spin, also called as the soft spin, was carried out at 2,400 rpm for 8 to 9 minutes. This has helped to separate the PRP from the platelet poor plasma. PRP was then preserved inside the platelet agitator incubator till a few minutes before the onset of the procedure. Initially, after exposing the bone defect, the autologous bone graft was procured from the mandibular symphysis region. Small bone grafts were taken and then were sintered using bone mill. The PRP, which was derived from the patient's whole blood, was mixed along with the bone substances such as calcium sulfate and autogenous bone graft particles and was made into a putty-like consistency. The PRP was applied over the overlying soft tissue graft, which was packed incrementally by dry sand stratification technique. Grayscale analysis was done using the Coral Photo Paint XT software. This helped to measure the bone density of the defect. The bone density over the defect was measured in different grids which were superimposed on the digital OPG. The normal bone defect density was also measured. The difference between the normal bone density and the bone defect density was measured preoperatively, immediate post-op, 5th, 13th, and 20th week. The bone formation was observed by the decrease in the grayscale value between the normal bone density and the bone defect density in the subsequent follow-up radiographs. The residual defect size measurement was also undertaken in the same Coral Photo Paint X-ray software. The delineated defect area, which was marked, was separately taken as an object, where its height and the width is measured using pixels. This is a radio opacity scoring scale which was utilized by the four and was evaluated by 4 independent blinded observers, where the following criteria was noted for bone formation. These scoring sheets were evaluated for 5th, 13th, and 20th week. The digital radiographs for both the study and the control group were shuffled and arranged in a Microsoft PowerPoint presentation. This was further analyzed by 4 independent blinded observers who gave a final score. Coming to our results, there's a drastic increase in the bone density in the study group, where you can see there's a 91.6 is the bone density formation at the 20th week compared to 61.8 which was achieved by the control group. So statistically also it is proven that there's a high significance in the formation of bone density. Coming to the percentage of the bone formation, as you can see it in the bar, compared to the control group, the study group has proven itself that by the end of 20th week, there's a drastic increase in the bone formation. The radio opacity score given by the blinded observers also coincided with the digital radiograph analysis, wherein there is a good amount of bone formation at the end of 13th and 20th week. The application of PRP in combination with bone and bone replacing material transformed the surrounding cells in the grafted bone sites. Many studies undertaken by Farrell and Agalu, they show that there is no benefits only if PRP alone is used. It has to be mixed with the bone substitute material. The autologous nature of PRP eliminates any disease transmission and immunogenic reactions. The PRP also has an anti-inflammatory agent like CCL5, which helps in the healing process. PRP facilitates healing by controlling the local inflammatory response. The exothermic reaction, which is generated by the mixture of calcium sulfate with PRP, activates the platelets. Calcium sulfate slowly releases these growth factors in a time-dependent manner. So we observed that in our study, by 5th week, the calcium sulfate is completely dissolved and it has occupied the space nicely so that it acts as a scaffold. Our study used non-invasive radiographic techniques. CT is also more important, can be used, but because of its high cost effectiveness, can be tried with normal OPT. The occlusal radiograph taken in a study would reveal a good amount of bone formation, which can be appreciated by 5th week, 13th, and 20th week. The cystic defect is completely healed. Many studies have been done in the past where they have talked about the efficacy of tracking rich plasma, which enhances the and the growth factors help to form a new bone. And the combination of platelet-rich plasma with many bone substitutes help to promote bone regeneration. Calcium sulfate and platelet-rich plasma is also a novel osteoinductive manager for bone regeneration. The study performed by Unity et al. In the year 2007 has supported this hypothesis. So, platelet-rich plasma as a reservoir of autologous bone graft was effective in inducing and accelerating bone graft, helped to regenerate osseous defects of the jaw. When combined with autologous bone graft and calcium sulfate, it showed a synergism in bone regeneration. The comparative study revealed increased radiographic bone density and rapid bone formation in the study group when compared to the control group. Thus, the combination of PRP calcium sulfate with bone graft proved to be a novel osteoinductive biomaterial. These are the references utilized for the study. Thank you. I would like to thank the organizers of the conference for providing me the opportunity. Thank you once again.